Hello. Today we're going to look at chapter 6, which talks about bones and skeletal tissue. We're going to learn how our body makes bone tissue, how it takes up or resorbs bone tissue, how it develops, and we're going to talk about the hormones that are involved in the process. So when after we're first conceived, and we're in utero still, our skeleton consists of mostly cartilage. Eventually, this cartilage gets replaced with bone, except for areas that need flexibility for while we're in utero and for the birthing process. So let's look at the skeletal cartilage. What is it? Skeletal cartilage is highly resilient, molded cartilage tissue that consists of mostly water. Cartilage has no blood vessels and no nerves. Our bones also have what is called a perichondrium. The perichondrium is connective tissue. It's dense connective tissue. And it's kind of surrounded by what's called a girdle that helps hold that cartilage in place. It prevents the cartilage from expanding out, moving in directions that shouldn't be. But this perichondrium also contains blood vessels. Even though the cartilage does not have blood vessels, cartilage still gets its nutrients through diffusion from the perichondrium. As we learned in chapter 4 when we talked about tissues, cartilage is made up of chondrocytes. If you remember, I said chondro means cartilage. So cartilage is made up of chondrocytes. Do you remember we talked about they live in these little lacunae, little divots down within the cartilage, and that lacunae around those chondrocytes is filled with like a jelly like matrix, extracellular matrix. It helps protect those cells, and it also helps make up part of the cartilage. So we've looked under the microscope at the 3 main types of cartilage during chapter 4. We looked at the microscopic aspects of them. But let's look at what they do for the body as a whole. Remember, we looked at hyaline cartilage. Hyaline cartilage is found on the ends of long bones, like your femur and your thigh. Both the top and the bottom, they have cartilage. It provides support. It helps make these joints flexible so they can move. So you can move your hip joint, your knee joints, your ankle joints. We need that. Hyaline cartilage is the most abundant type of cartilage. It is found everywhere throughout the body. As I mentioned, the joints, it's found in the articular joints, so they can move. Costal cartilage. So in the front, just on the sides of your sternum you can feel your ribs. That is technically cartilage right in that area. Your ribs come around and connect the cartilage and then attach to your sternum. Your larynx, or the respiratory, that is all made of hyaline cartilage. That trachea, there's cartilage rings that go around the trachea. Your nose cartilage, so your tip of your nose is made up of cartilage. That's hyaline cartilage. We have elastic cartilage. Elastic cartilage is very similar to hyaline cartilage, if you remember, by looking when we looked at microscopic pictures of it. The only difference is it had lots of those black elastic fibers. Those black elastic fibers are extremely important to elastic cartilage because we need it to be able to stretch and move. Like your ear. That whole external part of your ear is made up of elastic cartilage. The epiglottis, that is found in the back of your throat. And that moves up and down depending on if you're breathing or eating. We also have fibrocartilage. Remember, fibrocartilage, even the chondrocytes stain darker than hyaline and elastic cartilage. This is because fibrocartilage has a lot of collagen in it. It's found in the menisci of your knees. So there's cartilage in your knee joints that is in that knee, like on the top of the bottom part of your knee joint, that bone, there's cartilage that sits there. Those are your menisci, and that is where we find that cartilage. Also in your vertebral discs. So between each vertebrae in your back, there is a disc between it to help provide cushion and strength to the next bone, the bone above it and the bone below it. So these all help to provide that tensile force. So here's some of the different places we find the different kinds of cartilage. We have hyaline cartilage is all in blue. So you see the nose, see the ribs here? That is all hyaline cartilage. Your joints, there's blue on every one of these joints here. Here. Down here in the feet and the hands, there's a lot of hyaline cartilage. Elastic cartilage. Remember we said elastic cartilage was found in the ears. The epiglottis, which is up in here. Then the last type is fibrocartilage. That one was in red. See these red in here in the knees? That is where your menisci are. We also have your pubic symphysis is fibrocartilage, and you can see through the spine, there's red between each vertebrae in your back. Those are all fibrocartilage. So cartilage will grow in two different directions. What is called oppositional means it's growing out. So that outside surface lays a new outside surface, then lays a new outside surface, and a new outside surface. That's what these chondrocytes do. Chondrocytes are the cells that secrete cartilage. They make cartilage. Interstitial growth, we have inter, so it's in. They expand the cartilage from within, so from the inside. This is how cartilage is grown inside of that disc in your back, or the cartilage in your nose that's always kind of growing throughout your entire life. So interstitial growth is making those chondrocytes are making more cartilage to fill in the space right around those cells where they sit. So as we grow, our cartilage actually starts to calcify and turn into bone. It happens just as we age. As we get older, from kids to teenagers to adults, our bones are growing. That's how our bones grow longer. That's how our bones grow wider too. And eventually, where cartilage sat in those bones, where we call growth plates, those eventually harden and turn to bone completely by late teens, 20s. So bones have 7 specific functions for our body. Of course, they have to provide support. Without your bones, how could you stand up? How could you really move? You couldn't. They provide protection in your head. There's bones protecting your brain. There's bones that protect the spinal cord in your back. Those vertebrae and those discs in your back, those are all there to protect your spinal cord. Your rib cage is protecting your heart and your lungs. It's all very important. Your bones, along with the support I mentioned, they provide movement. So your legs, your arms, even your neck, your back, they all let you move in different ways. Your bones are storage. We store calcium and phosphorus in our bones. We also, in our long bones, make red blood cells through hematopoiesis. Bones can also store triglycerides or fat. Bones produce their own hormones. That's another reason why bones are a system. They're producing the hormone osteocalcin. And that actually regulates insulin, glucose, and helps to maintain your metabolism. So bones do a lot of different things for our body. They're not just there to help us get from one place to the next and protect our organs, let us move, but they're a storage site. They make blood cells. They make hormones. There's a lot of things that bones do for us. Our body has 206 named bones in our body. You're lucky we don't need to know all 206 bones in this class, but you are going to learn several of them. And we'll be doing that through lab. We're going to split this skeleton up into 2 parts. We have an axial skeleton, which includes your skull, your vertebral column, all the vertebrae in your back, your ribs. That is considered your axial skeleton. It's your head, your neck, and your trunk. Your appendicular skeleton is your arms, your legs, and anything that attaches your arms and legs to that axial skeleton. So like your clavicles and your scapula actually help to attach your arms to your body, and your hip bones, they attach your legs to your trunk. We have different kinds of bones, different categories. They are categorized based on how they look when we're talking about classification. So we have long bones. This says they're longer than they are wide. So all the bones in your arms and your legs, not your feet, not your hands or your wrists, just what make up the actual arm, the brachium, the antebrachium of your arm, that femur bone, tibia and fibula and the legs. Those are all long bones. We have short bones. The short bones are what make up your wrists, your ankles, even your fingers and your toes are considered short bones. The sesamoid bone, which is your patella or your kneecap, is also a short bone. It is found in that patellar tendon. Flat bones. We have several flat bones. We have all the bones of your skull are considered flat, or most. At least the ones that you can feel on your top of your head, those are all flat bones. Your sternum, your scapula, most of your ribs are technically flat. Even though they're curved, they're a flat surface. We have irregular bones. It's the fourth category. Irregular bones have very different shapes that can't really be categorized into any of the other three. Like the vertebrae in your back specifically, and your hip bones. Those are all irregular bones. So here's some examples. The long bone, this is our humerus or our brachium in our arm. We have short bone. This is a bone in your foot here. It's called the talus. We have a flat bone. This is your sternum. Irregular bone. This is one of the vertebrae in your low back. This is the shape of this specific vertebrae, showing how it is a very different shape from everything else. So we've looked at bone under the microscope. We can physically see bone, but we're also going to talk about the chemical properties of bone, because those chemical properties are very important to the rest of the body. So let's start with the gross anatomy. Remember, gross anatomy is what we can see. There's two different kinds of bone. We have compact bone, which has a dense outer layer on every one of the bones, but it also is smooth and solid. We also have what is called spongy bone. The inside of spongy bone kind of looks like a honeycomb. If you've ever seen a honeycomb, kind of needle-like or flat pieces of bone that are called trabeculae. There's open spaces between that trabeculae, and it's usually filled with red or yellow bone marrow. So here we have at the top, this is our spongy bone. This is our femur and the big bone in our leg. All those open spaces is what makes it spongy. It's called, all the actual pieces of bone are called trabeculae. We have some of this in the lab. That's kind of fun to look at. Then towards the bottom, we have that compact bone. This is where it looks all smooth and solid. We have some of our bones, we have both spongy and compact, like in the femur, because it helps to protect but it also makes bones not so heavy, which we'll talk about in more detail here. So our short, irregular, and flat bones. They're usually thin plates or spongy bone, or dipole is another name for spongy bone. Then it's covered by compact bone. So we usually have a couple layers with short bones, irregular bones, or flat bones. Compact bone is usually sandwiched between some connective tissue of some kind, help to keep it safe. The periosteum of these bones, it's what covers the outside of that compact bone. We also have an endosteum. Peri is for the outer side, endo is for the inside, and that's what covers the inside portion of that compact bone. And of course, with spongy bone, it's always filled with bone marrow. If it's these short bones specifically, even the irregular bones or the flat bones, if it's an area that moves, like your wrists, your joints, your fingers, your toes, they are all covered with hyaline cartilage. Hyaline cartilage, we remember from what we talked about before, is what helps joints move better. They give it a nice smooth movement. So here's a flat bone. If you see, we have compact bone on both the bottom and the top. And then in the middle, we have spongy bone. And you can see all these little trabeculae through here. And then through the open spaces, that is where we have bone marrow flowing through. So let's look at there's specific names for parts of a long bone. Long bones have a diaphysis, which is the shaft, which is the long part of the bone. So if I were to draw some kind of bone here, we have a diaphysis. We also have an epiphysis. The epiphysis are the ends of those long bones. The epiphysis usually has some kind of spongy bone in it, while that diaphysis is a tube shaped. It's got compact bone on the outside only, and then there's usually a cavity in the middle that has yellow marrow, in adults at least. There is usually a line somewhere in bone, usually around here and around here. These are where the growth plates are. So it's between that diaphysis and epiphysis, but this is the space specifically where bones will grow longer, where bones will help to grow thicker. This is where this occurs. It's called an epiphyseal plate, but also known as a growth plate. So here's that picture. We have the epiphysis at the top and the bottom. We have the diaphysis in the middle. You see that yellow bone marrow is in the middle of this whole diaphysis. You see at the proximal epiphysis, or the top, that is filled with spongy bone. So there's lots of spongy bone in there. That spongy bone helps to keep the bone light. It usually has arteries of some sort flowing through here for blood supply. We can see it on this bone because it's cut open, but here's that epiphyseal line. This is, at least at the top part, where this bone grew from. And eventually, because it's made of cartilage when it's growing. But once you're done growing, it ossifies or turns to bone. So here's another picture, another view. We have articular cartilage. On the outside, we have compact bone under that, and then the endosteum is the part that's on the inside of that compact bone, and then spongy bone in the middle. So as I've kind of mentioned, our bones tend to have two membranes. We have a periosteum and an endosteum. That periosteum is double layered. There's two parts to it. And it kind of covers the external surfaces of the bones, everywhere except at joints. Joints have a different makeup, but the periosteum is two layers that covers that outer part. We have a fibrous layer, which is the outer layer of that periosteum, and it's dense, irregular connective tissue. It also has what is called Sharpie's fibers. These help to secrete the bone matrix. We have an osteogenic layer, which is considered the inner layer of bone that contains primitive osteogenic stem cells. Osteogenic stem cells can turn into whatever kind of cells we need for bone, because osteo again means bone. So it'd have to turn into some kind of bone cell that we actually will utilize. That periosteum has nerves. That's why if you've ever broken a bone, it hurts because there's nerves in there. There's blood vessels. That's why sometimes when you break a bone, you get a lot of bruising. Blood vessels are breaking when that happens. And that continues into the shaft. There's a nutrient foramen, which is where those blood vessels come in and out of the bone from. We need that. Our bones need nutrients. We need blood supply going to our bones. It's very important. This periosteum is also important to keep our tendons and our ligaments attached to bones. This is where they attach. They attach to that periosteum. We also have an endosteum. That's also connective tissue, but it's on the internal surface of bone. And it covers the trabeculae of spongy bone. Endosteum lines different canals, and it contains those osteogenic stem cells. Again, those stem cells will differentiate into whatever types of bone cells we need. So let's take a look. This is the humerus. This is the bone in your arm and the brachium. We have our periosteum, which is this outer lining outside of the bone. These perforating or Sharpie's fibers are helping to attach this periosteum to the bone. The nutrient foramens are the little holes that go through bone. Remember, those are lined with endosteum. We have, after that periosteum came compact bone. After that compact bone is our endosteum. And then our inside is yellow bone marrow. So bones that have red marrow, which is found in trabecular cavities of spongy bone and dipole of flat bones. It's also flat bones like the sternum. Has red marrow. Newborns, we have that medullary cavity, and all the spongy bone contains red marrow in newborns. In adults, we have red marrow at the head of the femur, that thigh bone, humerus, which is on our arm bone, that brachium. We also get hematopoiesis, or red blood cells being produced, flat bone dipoles, and some irregular bones, like your hip bone, will make blood cells, red blood cells for your body. Because red blood cells tend to only last about 120 days. So there's always red blood cells that are being taken out of circulation, while new red blood cells are constantly being added to circulation. So we have to keep making cells. In somebody who's anemic means they do not have enough red blood cells, or they're not getting enough oxygen to their body. There's many different kinds of anemia. You go into it in Anatomy 2 in the blood chapter specifically. But that yellow marrow can convert to red marrow if somebody doesn't have enough red blood cells. So if they're anemic, if they've experienced significant blood loss, that'll make someone anemic. So they need that yellow marrow to turn to red marrow so they can start producing more red blood cells at a very quick pace. All bones in our body have markings. We're going to learn a lot of those markings, because those markings are where ligaments, muscles, tendons attach. Every place that a muscle attaches, a ligament or a tendon attaches, has a specific name for a reason. Because when we're talking about bones with muscles, and maybe something happened to a muscle or a bone somewhere, you got to know what's going on. So there's external surfaces on bones that have maybe a little raised area where a muscle or a ligament or something attaches. It may have a little spiral groove where an artery follows along. There's lots of different markings, just dependent on where it is in the body and what's attached to it. So as I said, there's different kinds. There's projections, which are outward bulges of the bone. There's depressions, like I said, like a groove for an artery or vessel, artery or vein or nerve, or a joint. There's different depressions for parts of our joints too. Openings. Your skull specifically has several little holes, openings. Usually they're passageways for blood vessels and nerves, which is exactly what it does on your skull. It's all very important. They all have specific roles. That's why they all have specific names. So here's the specific names of what a lot of these things kind of are. We have what is called a tuberosity. A tuberosity is usually a large rounded projection. A crest. A crest can be like a narrow ridge. Like here on your hip bone, this is your iliac crest. Just like your sit bones, this is what you sit on. That's your ischial tuberosity. Not only is it a sit bone, there's several muscles that attach there. We have a trochanter. Here is a trochanter in the femur. It's a very large, blunt, irregular shaped process. We have a line, which is a narrow ridge of a bone. It's a lot less prominent than a crest, but here is a line. It's the intertrochanteric line because there's two trochanters on the femur, large and a small. Tubercle. Tubercle is a smaller projection. Trochanters are big. Tubercles are smaller. Like here's what's called the adductor tubercle on the femur. Epicondyle. That's a raised area on or above a condyle. So we have a medial epicondyle. We also have a lateral epicondyle. Spine. That is a sharp point or projection, like your ischial spine on your hip bone. A process is kind of any bony prominence, like in your vertebrae in your back. This is the spinous process. There's many more, and we'll keep going through them as we get through to the bone chapter stuff specifically. But we have what's called a head. This is a rib. Every one of your ribs has a head. It has a facet where it attaches to the vertebrae, and then a condyle. This is on your mandible or your jaw. This is what helps your jaw move in the directions it moves. We have a groove, which this is also in the jaw, on your mandible in the jaw. We have a fissure, which is an opening, kind of slit-like opening, not like a circle, oval, or circular one, because that is a foramen. A foramen is a circular opening. You see, there's two foramen there. There's a foramen on each side here. A notch. A notch is an indentation at the edge of a structure. So they're looking at the exact same bone as up in this top part. This here is what they're pointing to in the picture below is a notch. A meatus is a canal-like passageway. That is your auditory meatus. Sinus. It's like if air-filled kind of space. Here's a sinus. Here's another sinus. It helps to lighten the skull specifically in this case. We also have a fossa, which is a shallow basin-like depression. This is where part of your brain sits. It's called the cerebellum. So let's look at the cells specifically that make up bone. We have Osteogenic cells, remember we've talked about these a little, they're the stem cells. Osteoblasts, I know I've said it before, but blasts are what make or secrete matrix. Osteocytes, we've talked about those with cartilage, they monitor. We have bone lining cells. Then clasts, osteoclasts, they resorb or take up bone. So let's look into more what each one of these does. I gave a little hint, but let's go into more detail about what these cells do. We have osteogenic cells or osteoprogenitor cells. Again, they're those stem cells and they will mature, they divide. They're found in the periosteum and the endosteum. They divide and they create those osteoblasts, osteocytes, osteoclasts. They turn into those different cells from one specific cell. We have our osteoblasts. They are called bone-forming cells because they secrete the unmineralized bone matrix that is called osteoid. It's made up of collagen and calcium binding proteins. Collagen actually makes up about 90% of our bone. That's a lot. But osteoblasts are actively mitotic. So they go through mitosis. So here's our osteoprogenitor cell. This cell here is that stem cell that turns into whatever kind of cell we need it to. We have our osteoblast. They secrete, remember we've talked about it with cartilage and with connective tissue. Whenever we see that word blast, it secretes matrix. So osteoblasts specifically are responsible for bone growth. They help keep our bones growing and healthy and strong. They're all extremely important. Let's look at what osteocytes are. Just like chondrocytes, fibrocytes. They monitor. So osteocytes, they don't divide. There's no mitosis going on, but they maintain the bone matrix. They're monitoring it. They act as a stress or strain sensor too. So if your bones are under a lot of stress for something, osteocytes specifically help to notify other cells of what's going on with this and help to respond to this kind of stress that the bones are under. So osteocytes actually communicate with osteoblasts and osteoclasts. So they can remodel bone, remake it up how it needs to be made. They're always working. We have those bone lining cells. These are flat cells. And they also help to maintain the matrix. They are periosteal cells on the outside and endosteal cells on the internal surface. So as you can see, endo inside, and then periosteals on the outside, just like the names of the surfaces of the different areas. Our last bone is osteoclast. I know I had said it before, but they break down bone or bone resorption. We do that when we need calcium, phosphorus. We do that Bone, it does that because it's constantly remodeling bone to whatever kinds of stresses the bones are put under. So osteoclasts are always active doing something. So they usually live in some kind of resorption bay because as they take up bone, they're building themselves a little divot or area to live in, to work in. So as they build, they make these little, or take up bone, I should say, they build these little divots down in there. They have a large surface area because they use enzymes to break down bone. But they also, with those enzymes, seal off areas from the surrounding matrix. They are technically considered a form of a macrophage. Because macrophages are technically part of our immune system, but they kind of take up bone as their job. So we have our osteoprogenitor cell, which is our stem cell. Our stem cells, osteoprogenitor cells, can become osteoblasts, or, and then some of those osteoblasts will become osteocytes. Osteoblasts maintain that matrix of the bone. Osteocytes help to monitor that bone. We also have our osteoclasts that resorb bone. So we can see some of, in this picture, we see some of this. We see that bone matrix in here. We have an osteocyte that's in a lacuna. This is where an osteoclast is working. So this here is an osteoclast. It has several nuclei. It has using enzymes to take up bone. Compact bone has some features to it. I know we've looked at it under a microscope in some detail, but here's some more. They have what is called an osteon or a Haversian system. They have canals and canaliculi. They have interstitial and circumferential lamellae. So let's look at this. Osteons are those structural units. So they are those, I know I've said it when we were looking at bone under the microscope, but they're those circular features of bone. Osteons, they kind of have these elongated cylinder shape that runs parallel to the long axis of bones. So we have some of these in here. They're little weight pillars. They help to keep the bone strong. So an osteon has those several rings. Each of these rings is called a lamella. They have collagen fibers because collagen is very strong. So it helps to resist that different forces, jumping forces, twisting forces. And then there is bone salts between those collagen fibers. So as you see, the lamellae are these circular parts that go through the collagen fibers. Each layer, the collagen fibers are running in opposite directions. The center, we have a central canal with an artery, a nerve, and a vein. They all help to protect the bone. So all bone has a central or Haversian canal. As I just showed in the previous picture, that's where your blood vessels and nerves. We have perforating or Volkmann canals. They're right angles to that central canal because there's little nerves and blood vessels that need to go the different layers. Just like in cartilage we've looked at, osteocytes will sit in little lacunae. We also have a canaliculi, which are those little hair-like projections that connect one lacunae to the next lacunae, so those osteocytes can communicate with each other. Osteoblasts use those canaliculi to connect with each other too. They have to communicate. We need communication between our cells, so they're doing the same thing. We have interstitial lamellae and circumferential lamellae. A lamellae is not part of that osteon. So some parts like fill in between those osteons, others are kind of remnants of osteons. That's where interstitial lamellae are. Well, circumferential lamellae are deep to that periosteum. If you remember that periosteum is that outer surface. So it's just deep to that, but it's superficial to that endosteum. So it's kind of between the two. And they run that entire surface of the diaphysis. So that whole long portion of that bone has circumferential lamellae. And that's what helps keep your bones from breaking when you twist. So here's what we see microscopically under a light microscope. Here's what we see under an electron microscope down in the two down in the lower right corner. But you see, we've got central canals here with arteries, nerves, veins. We have little canals, perforating canals that go right angles to those, so you can actually see how they connect to each other. We have our canaliculi, which are these little lines that go between the lacunae, so cells can communicate with each other. And then the bigger divots in here are the lacunae where osteocytes hang out. What about spongy bone? Spongy bone isn't poorly organized. It may seem like it just because it's lots of little pieces of trabeculae. But if you've ever seen a bridge with a lot of suspension cables, that's what this is kind of like. It's providing a lot of support. So we don't need osteons in spongy bone. They do have lamellae and osteocytes, and they do connect by canaliculi. But capillaries don't need to go through little perforating canals. They can just wind right through that spongy bone. This picture we've looked at before. It looks kind of all over the place, but it really has a whole purpose to it. It helps to keep the weight between the bones in place. It's very important. So as we talked about a little bit when we looked at the chemistry of the system at the beginning of like in chapter 2, bone has organic and inorganic components. So those organic are those osteogenic cells, osteoblasts, osteoclasts, bone lining cells, osteocytes, and osteoid cells. Those are all organic components of bone. Osteoid is what's secreted by osteoblasts. That's that matrix. That matrix is called osteoid. It's ground substance, collagen fibers, because we need it to be strong. Collagen is very strong, but it's also flexible. Our bone needs to have a little bit of flexibility to it. And that's what collagen helps to provide. Our bones actually have what is called sacrificial bones. And it's around the collagen. This sacrificial bone is used to stretch and break to kind of dissipate and prevent fractures. Our body makes places to kind of fracture or break because they don't want the entire bone to break. Instead, they'd rather have a small portion of that sacrificial bone break. So if there's no trauma, then that bone just reforms. Bone is pretty good at reforming itself. It does a pretty decent job at it. What about those inorganic components? We looked at the organic, which makes up most of the cells, the collagen, and the matrix. But we have what are called hydroxyapatites or mineral salts. That's 65% of the mass of your bones. That's quite a bit. But that's calcium, phosphate, crystals. That is deposited around the collagen fibers. And that's what makes your bones so hard, is that calcium phosphate crystals. It also helps resist compression. That's the last thing you want, is your bone to break under compression. So bone is only half as strong as steel in resisting compression and as strong as steel in resisting tension. Thought that was kind of interesting. That's why bone has all these mineral salts in it. That is why you can find bone for decades after somebody has died. Well, and everything else is decomposed away. We still have bone. And that's because of all those calcium phosphate crystals that are in our bones. So the form of our bones actually hardening is called osteogenesis or ossification. This is the process where our bones actually get hard. Your skeleton in utero actually starts to form in month 2 of development. So by about week 5 on, your bones and your skeleton are developing. Then your bones continue to grow until early childhood. But your bones are constantly remodeling and repairing themselves for the rest of your life. So in utero, all the way up until week 8, our skeleton or bones is more of a fibrous membrane and hyaline cartilage. They start to get replaced with bone tissue. So endochondral ossification, that was from the inside. That bone is formed when it replaces the hyaline cartilage that once made up that area. At that time, bone is called cartilage and endochondral bones. And that's how most of your skeleton forms. We have intramembranous ossification. And that's where we have what are called membrane bones. In endochondral ossification, all the bones inferior to the base of your skull are formed, except your clavicles. Those are the bones that make up your collarbone. This begins during your second month of development, the later part of the second month. It'll take that formed hyaline cartilage that was before it was ossified into bone, and it forms primary ossification centers in the center of the shaft. So remember, we have in a long bone, those primary ossification centers, because the bones aren't that long at that point, are right in the middle here. And then as that bone grows, those ossification centers move further apart. We keep blood vessels by these ossification centers because they need constant nutrients to replicate, to grow. Mesenchymal cells, those are another type of stem cell. They specialize into osteoblasts that help secrete that matrix in utero. So let's look at the 5 steps in the process of ossification. So we start with that bone collar around the diaphysis of cartilage. So here's that bone collar that forms around the diaphysis. The whole blue always signifies that hyaline cartilage. So then we have these little bone collar that's made on the outside. We also have this little tiny ossification center. As we keep growing in utero, cartilage, because your bones start being made of cartilage, they start to calcify. So they get those calcium deposits. That happens in the middle of that diaphysis. It develops some cavities. We need those cavities for blood vessels to get into. We get what's called a periosteal bud that forms that internal cavity. That diaphysis, which is the long middle part of the bone, keeps growing longer. We get secondary ossification centers at the epiphyses. Here's your secondary ossification centers. Those eventually turn into your growth plates, your epiphyseal plate line. And that's childhood through adolescence. That growth plate stays as hyaline cartilage, but it still is, cells are replicating in there. Cells are constantly growing and letting your bones grow. So that intramembranous Ossification, intra is the inside. We have the fibrous connective tissue in there. They're all made with those mesenchymal cells, so those stem cells. This is the frontal, parietal, occipital, temporal, and clavicle bones. So the bones at the top of your skull that protect your brain and your clavicles or your collarbones. So there's four major steps that are involved in this. Our ossification centers. So let's look at this here. Our ossification center develops into the fibrous connective tissue. We have those mesenchymal cells floating around in here. Those are making our osteoblast cells that are starting that primary ossification center. Osteoid is secreted and then it calcifies. So we have many osteoblast cells on the outside of the bone. We have osteocytes. We have two of them on the inside of the bone monitoring the bone that was just made. That makes spongy bone and periosteum that eventually forms. So those osteoblasts are laying down osteoid, which is that matrix. Its blood vessels come in and help to provide more nutrients to keep the bone growing. And then compact bone replaces that immature spongy bone. And that's just deep to the periosteum, and that's where red marrow develops. So this whole outer surface out here, that's our periosteum. We have our spongy bone in the middle, which is filled with red marrow. That is all of the steps here to how bone is formed. So after utero, postnatal growth. So after we're born, we've kind of looked at it, but bones grow lengthwise by interstitial growth. Interstitial or longitudinal growth at those epiphyseal plates or those growth plates. They will increase in thickness through oppositional growth. So they grow out through oppositional and they grow longer through interstitial growth. Did you know that some of our bones of our face actually continue to grow throughout your life? They never stop growing? Kind of interesting. So when bones are growing, there's different areas. Just like when we looked at the skin, there's different layers of that skin. Different areas do different things. Bones are the same way. We have what is called a resting zone. That is made up of cartilage. That's on the epiphyseal side of the epiphyseal plate. We have the proliferation zone. That's also an area of cartilage. It's on the diaphysis side. So if I were to draw out a bone here, my diaphysis is the long part. The epiphysis is the ends. So if I have a growth plate in here, my resting zone is closer to that epiphysis. The proliferation zone is closer to the diaphysis. We have what is called a hypertrophic zone. That is an area with older chondrocytes, chondros cartilage sites, their cells within the cartilage, but that's closer to the diaphysis as well. We have lacunae in this area that enlarge and erode. So those chondrocytes, their home that they're living in is kind of eroding. We have the calcification zone. That's where cartilage starts to calcify. Those chondrocytes die and deteriorate. We don't need chondrocytes in our bone. We need osteocytes in our bone. So in that ossification zone, we lose those chondrocytes, they die. When the chondrocytes die, they leave spicules of calcified cartilage. Those spicules are eroded by those osteoclasts and turned into new bone by osteoblasts. Osteoclasts take up that bone, those spiculae, and osteoblasts come in and lay down that new bone where those chondrocytes once lived. Then it gets replaced with spongy bone. So here's an X-ray of what these growth plates or these epiphyseal plates actually look like. In an X-ray, you don't really see cartilage. You only see bone because of the calcium phosphate. So that's why it doesn't look like the ends of the bones are actually attached. That is because there's cartilage in there, and cartilage doesn't show up on X-rays. So we have our resting zone. That is at the top part. Our proliferation zone. This is where cartilage cells are they're going under mitosis. They're replicating. The hypertrophic zone, cartilage cells enlarge. Calcification zone, that cartilage gets turned into calcified bone. The cells of cartilage die and they get replaced by osteoblasts that turn that area into new bone. Our ossification bone or zone is where that bone is forming. So on the right, we have a drawing. So diagram C over here, this is a drawing, while diagram B, that is what you actually see under the microscope. If you take a slide of this area, this is what it would look like. So when our bones are done growing, as we near the end of our growths, those chondroblasts don't really divide as much. They're not creating as much cartilage because we don't need it anymore. The epiphyseal plates, those thin, they get smaller because we don't need to grow for the rest of our life. That growth plate or that epiphyseal plate is replaced with bone. That's what makes our bones look solid in one piece when we're adults, because that whole epiphyseal plate gets replaced by bone. Females, that usually occurs about 18. Males, that usually occurs around 21. That's when these growth plates kind of close up. Your bones can grow in thickness throughout life. Just because they stop growing longer doesn't mean they're going to stop growing wider. They can grow wider. They grow wider due to different stresses on the body. They may need to grow thicker to take on more weight, increase stress, muscle activity. That can all cause your bones to get thicker. So when that happens, osteoblasts secrete bone matrix on that external bone. Osteoclasts remove the bone on the end osteal surface. So it's making that canal through the middle of long bones bigger, and it's getting replaced on the outside of the bone to make your bone thicker though. Usually there's more buildup though than breakdown. That's why bones get thicker. But we want strong bone. We don't want heavy bones. That's why the middle of long bones and that shaft of those long bones, it's usually kind of hollow. It's filled with more of a fluid like marrow because it's not heavy like like bones and calcium phosphate bone crystals put in there with collagen. So here's how our bones before growth and how that growth plate just continues to move with the bone as it grows, because the bone is being pushed this way down as it's growing. That is why bone grows up and our growth plate actually moves up with it. Our bone can also grow out through oppositional growth. Our bones are actually monitored through growth hormone. It's a hormone that is secreted by the brain to actually help stimulate the epiphyseal plate to grow. Those growth plates to actually secrete cells and grow and make you grow taller. Growth hormone does that. Your thyroid hormone, that kind of monitors the activity of growth hormone. Make sure that we're not getting too much growth hormone and we become like 7 foot tall, or not enough growth hormone and we end up like 4 feet tall. Testosterone in males and estrogen in females actually promote growth spurts. So that's why when puberty starts, all of a sudden you spring up and grow taller. They're also what lead to the end of your growth. They stimulate the closure of your growth plates, testosterone and estrogen. If we have too many hormones, as I kind of already mentioned, we'll have some kind of abnormal skeletal growth. Too tall, too short, different lengths of arms or legs, that's even possible. But that's why hormones are monitoring all of this to make sure that that does not happen unless it's something abnormal. About 5 to 7% of your bone mass is recycled each week. Spongy bone is replaced every 3 to 4 years, while compact bone is replaced every 10 years. Kind of cool. Your bones are constantly remaking themselves. They're remodeling all the time. They're depositing calcium phosphate salts. Those osteoclasts are resorbing or taking up bone, where those osteoblasts are then rebuilding that bone. So bone resorption, as I've said several times, is the job of osteoclasts. They break up the bone matrix They could break it up because we need more calcium in our bloodstream. They could just be remodeling bone. They could be laying new bone down from a fracture or breaking up the bones from a fracture, and so osteoblast can build more smooth bone again. So they make depressions and grooves when they break down the bone. They actually use enzymes, lysosomal enzymes and protons, to digest that matrix up. They take those calcium salts into soluble forms. They can be released into the bloodstream. Osteoclasts, since they're technically part of our immune system, they can phagocytize dead osteocytes. So they can actually take, as osteocytes die, they take them up, and along with when they're taking up bone, they're like, here's a dead cell. We don't need it. It needs to be replaced with a living cell. Let's take this up so another one can get in its place. When resorption is complete, osteoclasts undergo apoptosis, or programmed cell death. So it's genetically programmed that when they're done with their job, they die. That's just their life cycle. Osteoclasts are actually what activate parathyroid hormone. Parathyroid sits on the back of your thyroid gland, but those parathyroid hormones actually stimulate calcium, monitoring calcium in the blood. They also help with the immune T cell proteins as part of your immune system. So it does all kinds of stuff. So as we've said, that new bone matrix is deposited by osteoblasts. They're the ones that are laying down bone. They have an osteoid seam, which is actually a band of unmineralized bone that marks an area of new matrix. We have a calcification front, which is that transition zone between the osteoid seam and the older mineralized bone. So as osteoblasts are creating new bone matrix, there's a seam between the new bone and the old bone, and then there's kind of that transition. That's also kind of that transition bone or zone. And that's a trigger for new deposits, but it's not kind of confirmed. It's kind of hypothetical guesses as different mechanical signs. Increased concentrations of calcium phosphate. Matrix proteins that bind to and concentrate calcium, or appropriate amount of enzyme alkaline phosphatase for mineralization. These are all different thoughts on what kind of triggers the deposit of new bone. It's stuff we're doing, that is research is being done on. So what controls remodeling? A lot of it is hormones, but it's also in response to mechanical stress. So just like a lot of other things in our body, most hormones in our body have a negative feedback. Negative feedback is where we're trying to return things to normal, to that homeostasis. So our body needs to keep a certain calcium level in the blood. If our calcium gets too low, we're going to take up bone to secrete calcium into the blood so our levels can get back to normal. If our calcium level is too high, there's other hormones that say, hey, take some of this calcium out of the blood and put it into bone. We don't need it right now. We also could, Why we need calcium in the blood? Nerve transmission, muscle contraction, blood coagulation, nerve and gland secretion, cell division. We use it for a lot of things. So we need calcium in the blood so it can get into cells to help us with what we're trying to do. But we store about 99% of our calcium in bones. So all we have to do is go take up a little bone. Those osteoclasts take up a little bone and we can get calcium back into our blood. We use vitamin D to actually help absorb calcium from our intestines. Because some of our hormones, like our skin, makes vitamin D. That vitamin D will help bring calcium out of our intestines and absorb them into our system, into our bloodstream for any of the activities that listed before. So what are some of these hormones? We kind of mentioned parathyroid hormone, but parathyroid hormone is when we don't have enough calcium in our blood. It's too low. So that's when osteoclasts will resorb bone. They release that calcium into the blood. When the correct amount of calcium is in our blood, parathyroid hormone stops secreting. Because we don't need too much calcium in the blood. We need just enough, just the right amount. Calcitonin, that comes from our thyroid. But that is released when we have too high levels of calcium in our blood. So if we have too high of calcium in our blood, calcitonin is secreted, and that is where osteoblasts take some of that extra calcium and they turn it into bone. So we can store our calcium in our bone. So it's a nice one of those homeostatic balances. We need to keep the correct amount of calcium in our blood. Parathyroid hormone gets stimulated if it's not enough, while calcitonin is secreted if it's too much. So our calcium levels change in our blood all the time. But if there's an extreme change, that can actually cause some pretty severe neuromuscular problems. Just like everything else, every condition has a name. We have hypocalcemia. Hypo is low. So if we have low levels of calcium, it causes hyperexcitability of muscles. Well, hypercalcemia, hyper means high. So high levels of calcium, we have too much calcium, our muscles may not respond. We have too much calcium for a long period of time, high blood levels. It can actually cause calcium clots in blood, kidney stones, and those aren't, from what I've heard, very uncomfortable. And I actually saw an electron micrograph of it the other day, and they're very pointy, those kidney stones. So people describe them like razor blades going through when they go through the ureters to the bladder. There's some other hormones that control calcium. Leptin. Leptin is released by the adipose or fat tissues. Leptin actually plays a role in bone density. It inhibits osteoblasts from building too thick a bone. Serotonin. Serotonin is usually used to regulate your mood and your sleep. They also interfere with osteoblast activity. We get serotonin from the gut, and it is secreted into your blood after you eat. That's what makes you happy after you put food in you is that serotonin. But it inhibits bone turnover after a meal. So bone calcium doesn't get taken up from the bone. Instead, we get new calcium from our food. So serotonin kind of stops osteoblasts from building new bone and lets us get calcium into our bloodstream and where it may need to go. So our body is always responding to some kind of mechanical stress. So our bones get stressed when muscles pull on them. There's a specific law that's called Wolff's Law, and that kind of states that when bones grow or remodel in response to demands placed on them. So those stresses are usually off center. It allows bones to bend a little bit. But that explains your right-handedness versus left-handedness. The bones on your right hand, if you're right-handed, or left hand, if you're left-handed, are usually a little bit thicker because they need to do more work. It also talks about how bending compresses on one side and stretches on the other with Wolff's Law. So a diaphysis is thickest where bending stresses are greatest. Bones can be hollow because compression and tension cancel each other out in the center of bone. So let's look at this. This is our femur. There's usually a lot of load of your body weight right at the head of this femur. It's carrying all the body weight from your trunk, your head, your arms, all in that one spot. So, because of that, bone gets more compression on the inside and more tension on the outside. So your bone is constantly remodeling to help keep up with this. We don't want this bone to break under because of weight. Too much weight on it. That would not be okay. So as I said, it explains right and left-handedness. You get thicker and stronger bones on your right side or your left side, depending on what hand you are. Curved bones tend to be thickest where they're most likely to buckle. They want a lot thicker so they don't break. Those trabeculae and spongy bone, they form kind of trusses and lines of stress. Long, bony projections occur where heavy active muscles sit. So weightlifters, places where their muscles attach are a lot larger than, say, somebody who's bedridden or a baby who doesn't use their muscles like a weightlifter would. Their bones are kind of flat. While there could be a bigger bump, this is in a weightlifter's because there's a muscle that attaches here. But in a fetus or bedridden, their bones are pretty flat and featureless. There's nothing there. So those mechanical stresses we put our body under every day, they cause remodeling. They actually produce some really cool electric signals when bone gets deformed. We don't want deformed bone. So compressed and stretched regions tend to be oppositely charged. Compression and tension changes the fluid flow within that canaliculi, where osteoblasts and osteocytes kind of communicate with each other. That kind of helps to stimulate the remodeling. Osteoclasts are kind of like, hey, get to work. Osteoblasts and the osteoblasts are like, okay, I'm going to build here. I'm going to build here. They're all kind of communicating with each other. Our hormones. They also control remodeling because we need to respond to changing blood calcium levels. Mechanical stresses just determines where the bones are remodeled. Let's take a look at fractures. So what are fractures? A fracture is an actual break in a bone. When we're young, we usually do something to cause a bone to break. Fall off something, run into something, you name it, it could probably somehow break a bone when we're young. When we get too old, bones break due to weakness. Bones thin as they get thinner as we get older. So as bones continue to thin, they're more likely to break under weight, under mechanical stress. So let's look at the classifications of fractures. There's several different classifications on fractures based on how the bone breaks, where the bone breaks, and what happens to the skin and the tissues around it. That also affects what kind of fracture it could be. So the first type is the position of the bone ends. We have a non-displaced. It's the ends. It's when the bone kind of retains its normal position. Or we have a displaced fracture where it's out of alignment. We could have a complete break where it's broken all the way through the bone, or an incomplete break where it's just one part of the bone, just like one side of it could be broken. You have an open or a compound fracture. That's when the bone actually breaks through the skin. We have a closed or a simple fracture. Skin's not penetrated, skin's not broken. It's all internal. Could be by the location of the fracture, the appearance and the nature of the break. So here's some. We have what's called a comminuted fracture. It's where it's in 3 or more pieces. So tibia and your fibula here are broken. We have a compression fracture. This happens a lot in the spine of older menopausal women or people who have osteoporosis. So osteoporotic bone can compress and break. We have a spiral fracture. It's a common sports injury. It kind of spirals up the bone, as you can see in this x-ray here. We have an epiphyseal fracture. This is not a good fracture. This is between the epiphysis, which is the end here, and the diaphysis, which is the long middle part. It happens usually right along that growth plate. That's why it's not always a good thing. A depression fracture. This one looks like somebody got hit in the head. It's a depression into the skull. Green stick. The bone breaks, but it's not all the way through. Kind of like when you think of a twig that breaks, that's green in the middle, that's what this is. One side breaks, the other side bends. So, how are fractures treated at the hospital? Depending on what kind of fracture, they may need to reduce it, which means they put the bone back in the correct position. They can do it through a closed reduction, where they kind of move the bone back into place through the skin. You just hold it in place. There's an open reduction. That's where you have to start using pins, wires, plates, put the bone back together, and kind of let it all heal. Then you have to immobilize it. So they put it in some kind of cast. Depending on the break, they may even use some kind of traction to help hold that bone in the correct place it's supposed to be in so the cells can recreate the bone around it. Depending on how severe the break is, how old the person is, how many bones are broken, it's going to kind of depend on how long it's going to take to repair. The older you are, the longer it will take to repair. The younger you are, the faster it works. So when bones repair themselves, they form a hematoma, fibrocartilage callus, then we'll get a bony callus formation and then bone remodeling. So let's go through these stages here. Here's where we have a hematoma forming. A hematoma is a blood hemorrhage. A lot of blood collects in the area. This is what causes the area around a break to swell up and get pretty big. That's because we have a hematoma formation or a hemorrhage of blood. A lot of blood comes to the area. This is why it's painful. It's swollen, it's inflamed. It's all trying to the beginning of a bone fixing itself. Next, we get a fibrocartilaginous callus formation. Capillaries grow. We need capillaries because we need that blood supply to provide nutrients to the area. Phagocytic cells will clear the debris. Your immune system is always helping with everything in the body. So those phagocytic cells are your immune system coming in and cleaning up after that hematoma that was just created. Fibroblasts, fibros for cartilage, so fibroblasts are actually in connective tissue, so they secrete collagen fibers. So they're going to secrete collagen into that break to help strengthen that area, connect the bone back together. Fibroblast, cartilage, and osteogenic cells will start to make bone. That cartilage matrix comes first to help kind of put everything back together, and then osteoblasts will form spongy bone around it. This is called a fibrocartilaginous callus. So here the blue is fibrocartilage. We have lots of blood vessels that have come into the area. We need those blood vessels to form to help provide those nutrients. As this cartilage starts getting formed, we are making lots and lots of collagen fibers to help pull the bone back together. Now, this is usually within a week of a broken bone. We get a trabecular appearance. Kind of like with that spongy bone. That callus is converted to a hard bony callus of spongy bone. That continues for about 2 months until it kind of comes together and forms a union between the two. So do you see we start to get just spongy bone throughout the whole thing? Spongy bone just takes about 2 months to create. The whole thing is spongy bone. But now we need to create that hard exterior to the bone. So that bony callus, during that bony callus formation, there's lots of excess material that's around on the diaphysis exterior that gets removed. We need compact bone. Compact bone gets laid down because that's what we need on the outside of the bone. Once that happens, we start to look a lot like regular bone again. This is where our break was. Still a little bit of spongy bone in there, but it's turning into compact bone, which is what we have on the outside of these long bones. So we also have some different kinds of bone disorders. They're not usually good. So it usually has something to do with either too much bone being laid down or too much bone being taken up. So the three main diseases we're going to look at in this class is osteomalacia and rickets, osteoporosis, and Paget's disease. Osteomalacia and rickets, they're the same thing, but osteomalacia is in adults. Well, rickets is just the children's name for the same thing. So osteomalacia, there's poor mineralization of bone, not good. So they make the osteoid, but they don't put calcium salts down. So their bones are very soft. They're very weak. It's painful to move. It's the same thing that happens in kids, but in kids it's because of a vitamin D deficiency or not enough calcium in their diet. That's why it's so important for kids to get forms of calcium. Osteoporosis. This usually is a lot more common than it probably should be in postmenopausal women. Because as we learned before, estrogen helps to maintain bone. Well, after menopause, women aren't getting the same estrogen being secreted from their ovaries as they were during their reproductive years, premenopause. So osteoclasts are working harder to take up bone than the osteoblasts that are building bone. So bone mass actually goes down. The matrix is the same, but the masses, there's not as much calcium phosphorus salts in there. Spongy bone of the spine and neck of the femur are the most susceptible. As we looked at those compression fractures, that's where it's most common in somebody with osteoporosis. So here's what normal spongy bone will look like. Here's what the spongy bone of somebody with osteoporosis looks like, just underneath the normal bone. You can see bone doesn't look as strong. It looks very weak in comparison. So as I said, it's usually postmenopausal women, usually 30% of women between 60 and 70, but 70% of women by the age of 80 are affected. That's a lot. I'd also mentioned how estrogen plays a role in bone density. So when those hormone levels of estrogen drop, their risk significantly increases. Men are pretty safe from osteoporosis thanks to testosterone. Here's another reason why. Insufficient exercise to stress bones. This is why we need to exercise, because this is what helps keep your bones strong, especially after menopause. We need to keep stressing our bones to keep our bone density up. It is extremely important, especially as we age. Not enough calcium and protein in our diet. Smoking can cause osteoporosis. Unfortunately, the one thing we cannot control, genetics. We have zero control over our genetics. Thanks, Mom. Thanks, Dad. They're the reason certain things happen. It's just coming down that family line. Hyperparathyroidism. That's causing too much bone to be taken up. Diabetes. That's another one. Too much alcohol. Certain medications can cause it. So what are the treatments for osteoporosis? Of course, calcium. Make sure you're getting enough calcium. But you also need vitamin D, because vitamin D is what brings calcium, helps calcium absorb from our intestines. Those weight-bearing exercises, extremely important. Hormone replacement therapy. When the first 3 are not enough, that's the next one. It'll slow bone loss, but it doesn't reverse it. Weight-bearing exercise can reverse it. It's not, doctors don't like to give hormone replacement therapies because it can cause a lot of other problems. Heart attack, stroke, breast cancer. So they'd rather you do exercise. They'd rather you take calcium, vitamin D. There are drugs out there specifically for osteoporosis, like bisphosphonates, because they decrease that osteoclast activity and number. They get rid of some of those osteoclasts so there's not as many doing their job. Dinasium. It's a monoclonal antibody that helps to reduce fractures in men with prostate cancer. So this is used mostly in men. Men with prostate cancer aren't getting enough testosterone. So this is something that they can have, and it helps to improve bone density in men. So make sure you're getting enough calcium in your diet. This is stuff you can do now. Reduce consumption of carbonated beverages and alcohol. That carbonation in Coke, Pepsi, Diet Coke, they actually take minerals from bone. So carbonated beverages can decrease your bone density. Not okay. Plenty of weight-bearing exercises. That'll increase your bone mass. And it gives you a buffer against age-related bone loss. It is very important. Go for a walk. It will help your bones in the long run. Very important. The next one, Paget's disease. Paget's disease is when we get too many bone deposits, but it's not done in an orderly fashion. It's kind of done whenever and wherever they can find place and to do it. So bone grows too fast and poorly. It's actually called Pagetic bone because it's very spongy. It can occur in the pelvis, the spine, the femur, and the skull. Paget's disease is very rare before the age of 40. We don't know really what causes it. It could be viral. We really don't know. That's why it's possible. People usually have to take calcitonin, which is the hormone that comes from the thyroid gland. They usually end up taking bisphosphonates to get rid of some of those osteoclasts. But the top pelvis here is a normal pelvis, while this bottom one is a Paget's disease, Pagetic bone. You can see there's thicker deposits some places. There's not enough deposits in other places of those calcium phosphate salts. It's kind of just laid wherever. So we kind of talked about how bone develops. Let's look a little bit more into it. Because this is a way that they can actually determine how old a fetus is. Because bones ossify very predictably. So long bones begin ossifying at 8 weeks, and we get those primary ossification centers we talked about by 12 weeks. So that's how we know when a fetus is 8 weeks old. That's how we know when a fetus is 12 weeks old. So by birth, most long bones are ossified, except at the epiphyses. We need those growth plates. Those growth plates, as we've said, or those epiphyseal plates, we have them through childhood, through our teens. Females usually close around 18, 19, men around 20, 21. By the age of 25, all the bones are completely ossified. One of the last bones to ossify of your skeleton is your clavicle, that collarbone. That's the last bone to ossify around the age of 25. By 25, your skeletal growth ceases. It's no longer growing taller. So as you can see, you see those primary ossification centers at week 12. You see them here, 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 even here. You can see them here, 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 even in the fingers. So children and adolescents, they're usually building more bone than they're taking up. So bone formation exceeds resorption. So those osteoblasts are working harder than those osteoclasts. Men tend to have a greater mass of bone than females. It just happens that way. In young adults, both are pretty balanced, men and women, for bone resorption and bone formation. They're pretty balanced out. But by the time we're an adult, bone resorption exceeds formation. So more bone is being taken up than being laid down. That's not good. Another reason to exercise. Weight-bearing exercise is so important to your bones. So your bone density is always changing. A lot of it, of course, is by those genetics. So there's a gene for vitamin D cellular docking that determines the mass early in life and osteoporosis risk in old life. It's kind of interesting that there's a gene that determines that. So as you get older, just like everything else, your bone mass will go down, the mineralization of your bones goes down, so how much calcium is in there. Your healing ability goes down. Just like I stated earlier, the older you are, the longer it takes for your bones to get better. And beginning in the 4th decade, so in your 40s, everything is on a decline in your 40s. Your skull, those bones don't change, thankfully. They keep your brain protected your entire life. And bone loss is the greatest in whites and females. Another reason, if you fit in those categories, to go exercise. That is everything on bone tissue for today. Thank you very much. Bye.